acknowledged. Good evening and welcome to this sixth meeting of the Adult Social Care and Health. I am Councillor Marwan Al-Naji, the Select Committee Chair. This meeting is being held in accordance with recent government regulations on holding virtual meetings. Please bear with us if we run into any technical challenges during the meeting. In line with the government guidance that everyone should stay at home as much as possible, this meeting is being held via Microsoft Teams live conference, and all the committee members, council officers, and the parties who wish to participate in this hearing are joining us from remote location. The event is also being streamed live. The members of the public and the media are welcome to follow the meeting remotely and listen to the discussion. I would like to welcome any first-time viewers, listeners to this Adult Social Care and Health Select Committee.
Chair, sorry to interrupt, it's Yasmin. Can I suggest that you turn off your video?
As in all our meetings, I think it would be appropriate. Thank you. As in all our meetings, is it better, Yasmin?
Yep.
Is it clear now? Hello?
Yeah, you are clear now.
As in all our meetings, I think it would be appropriate for us to start with a 72-second silence to remember those who lost their lives in the Grenfell Tower fire tragedy. So can we have 72 seconds, please, silence, starting now.
The 72 seconds has ended, Chair.
Thank you, Yasmin. Continue. At the outset, I would like to ask members of the committee only to unmute their microphone when they are addressing the meeting. Likewise, to save bandwidth, I would ask that councillors only switch on their cameras when speaking and remember to switch them off after having spoken. If a councillor wishes to speak on a particular item and has not been called to speak, please indicate by using the hand up feature or by drawing my attention speaking up. To assist your fellow councillors, officers, and members of the public watching online to identify you, please state your name before you speak. Now, further to our rules before, as we are entering, and we are now in a pre-election period, may I, during this current pre-election period, the council has to be careful that it does not do anything that might cause a reasonable person to conclude that it is spending public money to influence the outcome of the election. Councillors and officers, we are all need to be alert to this. So in our meeting this evening, whilst we business as usual, we must continue reports and discussion about matters that could have a bearing on the election should be avoided, please. I would like to ask anyone participating in this meeting that you do not speak in a way or on issues that could be seen as seeking to influence voters. If for any reason your connection drops out and you miss something, if my connection drops, I nominate Vice Chancellor, Councillor Max Chauhan to take over the meeting. I confirm that I have no declaration of interest to make regarding any items on the agenda. I will now turn to my committee members. Could members also let us know if you have any declaration to make after introducing yourselves? So may I have the members, please? Councillor Chauhan.
President, nothing to declare, thank you.
Thank you. Councillor Idris.
Good evening. Nothing to declare. Thank you, Chair. Thank you.
Councillor Spalding.
Councillor Mark Spalding, Earls Court Ward. I have no declarations, but I am a patient at a GP surgery, and I believe one of the clinical leads from my surgery is here this evening. And I've also been a patient at Chelsea Westminster Hospital.
Thank you, Councillor Spalding. Councillor Sexter.
Good evening, Chair.
Good evening.
I'm the employee for CNWL.
Thank you. And Councillor Williams.
Councillor Charles Williams, Redcliffe Ward. I am the council's representative on the CNWL governing body, but I have no interest to declare.
Thank you, Councillor Williams. And Councillor Round, I can see Laura here.
Hi, Councillor Round, Pembridge. No declarations of interest for me. Thank
you. And Councillor and Co-op T members, Christine Vigars.
Hi,
of Health Watch.
Christine Vigars, and I'm Chair of Health Watch.
Thank you, Christine. So therefore, we have, I believe next item A1, apologies for absence. We have no apologies. All committee members are here. We had the declaration of interest done. I call on item A3, please. Minutes of the meeting held on the 22nd of February 2020. The minutes of this meeting have been circulated. Is it your wish that they are be signed as a correct record, or do you have any observation on them? May I call on the committee members, please? Shall I take the silence as a correct record for the meeting minutes to be signed?
Agreed.
Thank you. Now I move to item A4 on the agenda, and this is the CNWL recommendations, and also we are including the Professor Appleby report on suicide prevention. As part of the committee review of mental health in North Kensington, we are examining tonight the progress with the implementation of the recommendation on suicide prevention in North Kensington. As you know, Central and Northwest London NHS Foundation Trust, CNWL, invited Professor Louis Appleby in September to advise them on what additionally they could do in order to improve suicide safety in Kensington and Chelsea. Professor Appleby produced a report for CNWL, which being circulated, with a number of recommendations that were accepted by the Trust. These recommendations are now being put in place, and we are reviewing tonight the progress in their implementation. We have as a guest speaker tonight, which kindly accepted our invitation, is Professor Appleby, who is a Professor of Psychiatry at the University of Manchester and Director of the National Confidential Inquiry into Suicide and Safety in Mental Health. He leads the National Suicide Prevention Strategy for England. I am pleased that Professor Appleby has accepted our invitation to speak to us tonight about his reports and some of the key issues highlighted in that report. May I welcome Professor Appleby, and thank you so much for being here, as we know how busy you are, and we appreciate you made the time to speak to us. After Professor Appleby speaking for a few minutes, we'll hear from the national, for the central national, I beg your pardon, for the North Kensington on suicide issues. So may I extend the invitation for Professor Appleby to talk to us, please. Thank you.
Well, thank you very much for inviting me. It's a pleasure to be here. I want to start just by acknowledging the many people who spoke to me in the preparation of my report, local residents, community leaders, people who had a role as a frontline professional. People were incredibly patient and informative. And I just want to start by saying that. You've asked me to talk a little bit about the report, to highlight some of its key features just in a few minutes. And I thought I might do that in two parts. First of all, by talking about the general approach to suicide prevention, which my report suggests, and then to select some of the actions from the report. There's quite a long list of actions in the report, but I thought I might select just a few that illustrate the kind of approach that I am advocating. So first of all, the general approach. I think the first thing to tackle is the question of how suicide prevention can be a local priority at a time of global pandemic. Of course, public health, its resources, its attention is focused on coronavirus. How can we also be paying attention to suicide prevention? And in fact, that very issue delayed my report. I just need to emphasize that the field work was done in late 2019. The report was ready for publication about a year ago, but was delayed for 6 months because of that sense that this was not the right time, that the eyes of the system, of society, of governments was elsewhere in the early coronavirus pandemic. As time passed, it became apparent that wasn't really the correct view. It became apparent that the concerns about mental health that had been raised by the Grenfell tragedy were quite similar to the concerns which the pandemic was also exposing. And many of the themes that have become familiar during the pandemic were also the themes that had become part of my draft report. So themes of economic disadvantage, of ethnicity, of trauma and bereavement, of the vulnerability of children, all of these things are reflections of the pandemic and its mental health consequences and of the consequences of the fire. And for that reason, there is a much greater alignment between the two things. Not in any way are they in competition. They are quite closely aligned. And the solutions, the way out, the recovery from both involves some common actions. And I should say that that's regardless of suicide rates, because the evidence that we have is that neither the Grenfell fire nor the coronavirus pandemic has resulted in a higher suicide rate. That's probably not the issue. What it has done, what both have done, is raised risk, has raised vulnerability, and raised the importance of mental health to our recovery. So that's one aspect of the approach. This needs to be, suicide prevention is aligned with recovery from the pandemic. Secondly, that suicide is a complex thing. People's lives are complex. Suicide prevention is never one thing. It's complex too. And on the one hand, it is about safer services. It is about the mental health care that the local NHS provides. But it is also about the features of wider society. It's about those intangibles of trust and justice and accountability, themes which were recurring references for people that I met in my visits. This wider sense of not just individual risk, but the psychological safety of the community as a whole. If a community feels unsafe, if it feels there's a lack of trust, then vulnerable people in that society, people who are already anxious and at risk, will be put further at risk. So that sense in the community of its strengths and weaknesses, that's vital. That's vital to the specific issue of suicide prevention. It's, as I said, suicide prevention is a very complex thing. People's lives are very variable, but common themes in suicide prevention for suicidal people are feeling trapped, feeling abandoned, feeling unjustly treated. And that's for individuals, but it's equally true of whole communities and whole societies. Feeling trapped, feeling abandoned, feeling unjustly treated. Those are part of what puts people and communities at risk, as it has been here with you in Kensington and Chelsea. Thirdly, suicide prevention is a broad responsibility. It is very importantly the job of the NHS and also of local authorities, but it is not just their job. It is also a job of the third sector, of other frontline agencies, of all local leaders. Suicide prevention is not it can't be done part-time. It is a full-time job. It is in the sort of much well-worn phrase, it is everybody's business. Suicide prevention is everybody's business. It cannot just be the exclusive responsibility of one part of the local agencies. Fourthly, suicide is very closely linked to the economy. An economic downturn, a recession, is one of the biggest risks to suicide and to suicide prevention. And so the long-term economic recovery in certain parts of the borough are vital to suicide prevention. So they may not sound like suicide prevention, but how we deal with people who are in debt, whose jobs are insecure, whose housing is poor, who are homeless, those are just as much suicide prevention as the way that mental health services work. Fifth, there is an important paradox in suicide prevention, which is that the group who are probably at lowest risk in society, that's children and young people, are probably are certainly one of the highest priorities. So lowest risk, but highest priority. And that's partly because their suicide risk may be low, but their self-harm risk is high. So that's non-fatal self-harm. It's also the case that that the tragedy of young suicide is so great that they can never not be a top priority, even if rates are not particularly high. And then there is, of course, the long-term issue. Young people who are at risk from an early age go on to carry that risk long-term. And so a long-term strategy, any long-term strategy about mental health or suicide prevention has to have children at its heart. So that tells you something about the general approach which my report recommends on suicide prevention. I want to now, for a few minutes, just mention a couple of specific actions which are also listed in the report. First of all, there's the clarity about the suicide rate locally. I didn't find any evidence that the suicide rate was high after the pandemic, although I think it's likely that some individual suicides were related to the pandemic. Sorry, to the fire. Sorry, let me say that again. That I didn't find evidence that the suicide rate was high after the Grenfell fire, but I think it is likely that some individual suicides were related to the fire. That's not to say that people's concerns. I met a lot of people who were concerned about the suicide rate locally, but that's not to say that they were wrong. What they were reflecting is that general sense of insecurity that I was referring to earlier, that sense, that distress that many people felt after the fire had not, in their view, been fully heard. Now, that may be unjust to the many agencies who've worked hard locally, the many community groups and leaders who've, I think, worked incredibly hard to do the right thing. But that's how people felt. And so the issue of their concern about suicide rates is not just a matter of numbers. It's a matter of what it tells you about how they felt. Secondly, so that's about rates. Secondly, the need for a local suicide prevention strategy. There was already a strategy. I think it was pretty good, pretty comprehensive, but it could be developed. It could be made. We could ensure it's up to date. It could have senior local leadership. It could include more members of the local community. I personally would go further and say that Kensington and Chelsea should turn tragedy into something that has a positive future outlook and talk about a suicide-safe community, taking every measure that's possible. Not just a strategy that can be delivered through meetings, but a culture of suicide safety across the borough. Thirdly, there's the issue of data. No strategy can work well without good data. You need real time, that's immediate data, suicide figures recorded as they happen so that you are monitoring closely what happens to suicide rates, and the same for self-harm through working with local accident and emergency departments. Fourthly, there is the issue of mental health services themselves. So I understand that's what you're going to go and talk about after this. And mental health services are a key part of suicide prevention, of course, a key component of the leadership of suicide prevention. My recommendations on mental health services were partly about suicide prevention, but also about how services responded to ethnic diversity locally. That's just as much a part of safety as the specific suicide prevention measures. So, and by that I mean services which are integrated across mental health and social care and physical health care, services that are community-based, services that use the many strengths of the local community, a lot of strengths in community groups, quite creative community groups, I thought, and that can have a therapeutic role, a wider range of therapies for people who have been traumatized, people who are isolated, people in crisis, for families, for people who harm themselves non-fatally, people from a broad range of cultural diversity. Getting all of those things right for the local mental health care is part of suicide prevention. Fifthly, there's the issue of community engagement. It's very important. My point at the beginning that suicide prevention is very importantly about what the health service does, but also about the wider community. And that sense among many people that they were on the margins of the community is dangerous psychologically. And the opportunities for people to be part of their community through volunteering, for example, through playing a part in decision making about health priorities, where money is spent, what kind of services you have. That sense of community involvement is also a part of people feeling involved about the security and safety that I'm emphasizing. Sixth, there is the importance of aligning mental health recovery with economic recovery that I've referred to already, but there are some important examples of how to do that. Let me just mention one. I think building on the strengths of community groups, on how they work across an ethnically diverse society, how the third sector is strengthened. There is a lot of trust in the third sector locally, I found. All of that is part of mental health recovery, part of economic recovery. Seventh, there is, to return to my issue about young people. This is partly about how education and healthcare work together, teachers feeling confident that they know what to do about mental ill health. It's about those services meeting each other, understanding each other's concerns, supporting each other. It's about jobs and education for young people as they move from school into wider society. One of the most important things we can do to reduce the suicide rate is make sure that people have jobs, make sure people have a good education. If we do those things, then we are halfway to tackling suicide as a problem. And finally, there is the issue of communication. Time after time, people said to me that they didn't feel that those in authority were listening. Now, I don't know if that's true or not. That, in some ways, it almost doesn't matter if it's true. That's how people felt. And so the getting communication right is absolutely vital. I met so many people who are doing good work. It was a very moving experience to meet people who had gone the extra mile, who had worked with the local community and done sometimes some rather wonderful things. But still, people in the local community felt that they had been left to one side. That they and sometimes they didn't know about some of the initiatives that I felt were quite impressive. So the sense of getting communication right, making sure that communication is done in the right way, which is a diverse way. People need different things. Getting all of that right, that sense of ensuring that people feel listened to. Psychological safety includes feeling listened to. And if that means something as formal as a communication strategy, then I'm in favour of that. But in the end, it's about making sure that people can say they listen to my concerns. Thanks very much for listening to mine.
Thank you. It's an excellent positioning of all your hard work in our community, and I wish I missed that opportunity to meet you because I am a councillor in Nottingdale, and so hopefully we'll meet again in the nearest future to welcome you here. And thanks so much for this overall view about how you capture our community spirit in terms of positive outcome, and I'm sure the change of culture our council try to do, try to move closer to and this element of trust you highlighted repeatedly in your report to gain trust and move forward in addressing mental health in general. And this pandemic really has compounded our feeling as a community around Grenfell Tower. So that's a close proximity, and the community. I'm glad you've observed and you reflected that in your report in terms of resilience building, which is quite good initiative happening in the community post Grenfell. And thank you so much for the advice that definitely our officers in the council leadership will take on board in terms of listening for the better, in terms of moving and turning this tragedy of something we can have a suicide safety network, which we can really tell people around England how we coped and how we managed that issue, which is a very emotional and very difficult issue. Thank you so much again for being with us, and I'm not going to ask my committee members to ask you any questions here. If they want, they can do it privately. But I have one advice. I would like, since you brought again the long-term strategy in terms of addressing young persons, young adults moving forward, that because this is a long-term issue. What advice would you give if, like a young adult, reported to the teacher that young adult feels suicidal, and then the teacher just called the parent to collect that young adult, let's say around GCSE age? How would you give any advice to the academics or the school how to deal with it?
Well, I think the first thing to say is that I would always take it seriously. I made the point that young people don't have a high suicide rate, but on the other hand, when a young person talks in that way, it should always be taken seriously. Many of the factors that when young people die by suicide, I'm sorry about the slightly grim nature of the discussion that you have to have on these issues, unfortunately, I'm afraid.
Yeah.
But when a young person dies by suicide, very often the factors that precede it are individual to that person, and yet they reflect a young person's life. And families will often say that they didn't really see anything out of the ordinary, that the stresses that the young person was facing were quite similar to the stresses that a lot of young people face. So how can it be that one person reacts one way and other people somehow get through? And so I think in that's a very important observation that families make. And I think it means a couple of things. First of all, it means that most people get through, so that even these crises that they get into, the outcome tends to be more positive. But secondly, that we cannot easily distinguish who are the people who need additional support. So what do you do about that? The only way to respond to that is to accept what people say at face value and to do everything we can. Don't try to make too many judgments about who is at high risk or who is at low risk. If young people are talking in that way, we have to treat them as if the risk is high. And that means involvement of, I mean, it depends on the circumstances, but involvement of families, of course, but also involvement of whatever agencies, the social supports that they might need. It also means understanding how people view their future. In England, we have a problem that the suicide rate in England has been rising for about the last 10 years or so. A rather different pattern from so the suicide rate in young people, that is, has been rising for the last 10 years, different from the general population pattern. And that tells us that something is happening in the lives of young people that we have to be more conscious of and pay more attention to. And it does get down to sometimes nebulous concepts like hope and trust, and having a future. And our job is to, of course, protect the person when they're in crisis, but also to recognize that what lies behind risk for some young people is the sense of hopelessness, the sense that their future is not what they want it to be, that the values they want to live by are not the ones they see around them in wider adult society. And getting those things right, which is a long-term task, is a key part of suicide prevention, just as much as getting crisis services right.
Great, thank you so much, Professor Elby. Here I will conclude. You are welcome to stay when we are receiving the report from the CNWL on this. And if you want to take some comments later on, you are welcome. I will extend my thanks to you and on behalf of the committee. And thank you so much again for being with us, enlightening us on this very critical matter indeed. Thank you again, Professor Elby. Thanks. Now, if members agree, I will take CNWL report as read, unless we need some clarification. But I understand that Robin Doran, Chief Operating Officer of CNWL, and Anna Raleigh, our new Baybara Director of Public Health, are here to answer our questions. So welcome to Robin and Anna. And I will take questions to Robin Doran from members of the committee first, followed by councillors attending and members of the public who written to us regarding this topic. So can I now, Councillor Spalding, can we have your first question, please?
Thank you, Chairman. It's 3 points. I'll wrap them all up very briefly. I thought Professor Appleby's report was very educational. It was a great deal of in-depth information and a lot to absorb and a lot of food for thought and things that we can do and build on. But I did find 3 deficiencies in the way that this has been interpreted into our local context. I mean, basically, I find it difficult to draw any conclusions because there's no data, there are no statistics for us to compare our local situation with some sort of national benchmark to know that if our communities are suffering rates of suicide which are vastly greater or vastly less and so on, So I would have appreciated some data or statistics so that we can actually measure the depth of the problem. Secondly, I can't see anywhere in this report the emphasis that the largest cause of death in males under 50, the biggest cause of death in males is suicide. It's 3 times the rate for females. And I don't see that brought out anywhere, that the male population is extremely at risk of suicide. And I don't see anything in the report that's looking at any action or any support for young men specifically. And then thirdly, I see nothing in the report that looks at the fact this borough has 50% of our households are single person households, which is a statistic that is very extreme compared to the rest of the country. And I see nothing in this report that would allow us to support single people. Although I know that Dr. Karen Napier, about 10 years ago, did a big study in this borough of single households linked to depression. And I see no reference to that research work in here at all. So those are my 3 worries, that those are deficiencies in this report, which will hamper us taking effective action. Thank you.
Thank you, Councillor Spalding. I will take one more question and I will let the CNWL officers to answer. Councillor Williams?
Chairman, yeah, really 2 points. One is that, well, they're related. I think that, I've listened carefully to what Professor Appleby has just said to us, and that he put a great deal of emphasis on communication with the community. And I wondered what additional work is going to be done both by CNWL and by Public Health in the context of suicide prevention to do that. And secondly, there was a specific recommendation in his report relating to young people, and it says that there's should be a children, young persons mental health forum, bringing together schools, care, social care, and primary care. And if I may say, I think a rather dismissive response, saying there are currently multiple forums. Well, maybe, perhaps there are too many, but perhaps this is one we do need. So I'd like a response to both those points.
Thank you, Councillor Williams. Okay, we'll leave it to officers, please.
So Councillor, hi, I'm Robin Doran. I'm the Chief Operating Officer for CNWL, and I have the team here who are on the ground managing clinical services. So Dave Bailey, the Deputy Clinical Director, John Green, the Clinical Director, and Anne. I think Councillor Williams' questions are directed at us. I think Councillor Spalding's questions were directed at actually Professor Appleby's report, which I think is a different issue. But we'll pick up, first of all, the questions raised, the last 2 questions by Councillor Williams. Dave?
No, sorry, I think Councillor Spalding is asking question regarding your report, not the Professor Appleby report. Correct me if I'm wrong, Councillor Spalding, please clarify.
Chairman, it's it's how Professor Appleby's work is going to find traction and application in this borough. And I think my 3 points will hamper effective application of this research in our borough, because I think these are 3 key things that should have been addressed. So we've got a solid base for action.
All right, thank you. Okay, now it's clarified. Thank you. So over to you, Robin. Yeah.
Okay, so if I ask Dave Bailey, who's Deputy Clinical Director, to pick up, first of all, answers to Councillor Williams, and then we can come back, whether it's Professor Appleby or one of us who answers the questions from Councillor Spalding. So, David.
Thank you. Yes, to address Councillor Williams's questions. I think communication is very key. We know that we are talking into a community where trust has definitely been eroded and is completely an issue that reoccurs. And so a lot of time is spent amongst the many different agencies, not just CNWL, but the many different agencies, having conversations and building trust with communities. Again, I think that was highlighted in Professor Appleby's report about the importance of communities feeling heard. I think that for us, this has been a really important piece of work, which has, again, emphasised the need to work in partnerships with communities and with other providers, and with public health and our colleagues in the local authority, which we have been doing to address the various different points about how we are able to help communities talk more about their emotional health and well-being. And that seems to us to be a very fundamental part of suicide prevention, is the plethora of work that has been happening across all of the different agencies in equipping people with an emotional language to be able to talk about their feelings and to destigmatize emotional health and mental health, so that people know how to ask for help and where to go to ask for help. Early days, I think, in terms of being able to have a comprehensive view over all of that. But I think it certainly contributes to our feelings about working with communities to make communities feel heard and to feel that they are a safer place for people to live. Having said that, I think the impact of the pandemic has been absolutely crucial and significant for the North Kensington community, where I'm sure, indeed, as people have told me, it feels as though there's a second trauma on top of the initial trauma from the fire. So communities have felt very impacted by the pandemic. There were lots of things that were very reminiscent, I think, for some members of the community, in terms of not being able to get out and having to stay at home and feeling quite confined. Certainly concerns about children and young people in particular not being able to get into the normal habits of getting into and from school. And all of those issues, I think, have contributed to the community feeling more unsafe. But nevertheless, an important conversation for us to continue to have with communities about how we can enable them to feel more safe. I think in terms of the multiple forums for the children and young people, I think that there are indeed multiple forums for children and young people across the borough in terms of emotional health and well-being, and these are very welcome. I think that we work a lot with the partnership agencies in the voluntary sector, organisations such as Mind, who have schools teams who work, mental health schools teams who work in the schools. And together we are creating a network of support for parents and young people, working with teachers to help them identify signs of emotional distress in children and young people, and to be able to signpost families to where they are able to receive help and support. And that being largely focused on prevention. So preventing people from getting into a place of crisis by intervening much earlier, and providing help and support into families and schools, so that the emotional literacy is something that the young people are taking forward as they grow and develop in the North Kensington area.
Thank you.
Robin, I think you're on mute.
All right, so thank you, David. I think the points that were raised by Councillor Spalding are probably best picked up. They highlight, I guess, areas of concern about people who are vulnerable around suicide prevention, and it may well be best picked up by public health colleagues who are leading the work and the strategy on suicide prevention.
Okay. Any colleague from public health would like to come in?
Hello, Councillor. It's Anna Raleigh. I'm the new Director of Public Health here in the Royal Borough of Kensington and Chelsea.
Welcome. Good evening.
Good evening. I'm very pleased to be here this evening, but conscious I'm my second week in post. Therefore, I have asked my colleague, consultant in public health, Jeff Lake, to join me. And I'm going to invite Jeff Lake to respond to those points around the data, the high cause of death in male population, and also our single households. So over to you, Jeff. Thank you very much.
Thank you very much, Anna.
Thank you, Anna. There's Jeff. Welcome.
Thank you, Councillor. I think it perhaps is useful just to very briefly describe our approach to our suicide prevention strategy. So we have a strategy that covers a 5-year period and ends at the end of this current financial year. And we have a suicide prevention partnership that meets bi-monthly to deliver on the priorities that are identified in that strategy. And then that's basically reviewed annually with our partners. We review our data and we consider any particular changes and priorities that need to be made for the year ahead. And then just placing Professor Appleby's report in that broader context, his work was commissioned in order specifically to look at the concerns being raised in the North Kensington population. So it's a very particular area of attention. But I can pick up very quickly on some of those points that Councillor Spalding raised. So in terms of our local data, the suicide rate in Kensington and Chelsea does not differ significantly from either London or England rates. It is the case, both locally and regionally and nationally, that there are higher rates of suicide amongst young men. That is the case, and that is reflected in the annual review of data that is conducted as part of that partnership group's work, and indeed in terms of the action plan that is generated. So I should just very briefly like to cover where we are with this year's priorities. I think, and some of the successes that we've had this year to date. So in particular, we've established a group with our local universities, and obviously that they're a very useful partner for helping us to address some of those concerns about young men and young people broadly. That group has been established and it is now meeting. Also in relation to the concerns about young people, we have a particular priority this year in relation to self-harm. And thanks to David and other colleagues, we had a very successful session a few weeks back on self-harm, where we had 160 attendees from across our statutory, voluntary sector partners and community. I've never known a session that we've held in suicide prevention that's had that kind of attendance, facilitated no doubt by being on a digital platform, but that was certainly extremely encouraging for that work on self-harm and for our plans in that area. And then in particular, and this takes me into the area about our community-based work, we have a particular commitment this year to develop a local suicide-safe community initiative. And we've been working on that for some months now, since Professor Appleby's report. We've looked at voluntary sector partners nationally, and in particular, we've worked with a charity that works in Cumbria and leads on this area there and is something of a national example. and they have both provided training to local voluntary sector partners, and then we've looked at their training packages and how we can look to develop those, and with a view to developing our own model locally. So that is well progressed. We've recently just had the first of 2 workshops that are helping us to finalize our plans for that work before it is more formally launched. But I'm very pleased with the progress that's been made in developing our plans for a suicide safer initiative, learning from that practice elsewhere. There was also comment in particular from Professor Appleby about the response to the ethnic diversity of our borough, and just to pick up on that's been a particular area of attention as we consider how we address the stigma that surrounds mental health in a number of communities, and how we think about the offer that is provided in support of communities to ensure that it is culturally appropriate. And then just finally, and sorry if I don't wish to speak too long, I'm more than happy to take any more questions, of course, just on social isolation. So it is the case that we have a very high proportion of single households, and there was a session that was hosted by the mayor just before we went into lockdown. Some councillors might remember that session. And during COVID, we've certainly been cognizant that that's one of those areas of exacerbation, one of those risk factors that has been exacerbated in this period, along with bereavement, financial hardship, unemployment, and that those are all very much areas of attention during this time. So there is, whilst we've had obviously a huge amount of work in public health in terms of the immediate response to COVID, the suicide prevention work has actually stepped up frequency during this period, with a view to helping us to identify and mitigate any of those potential emerging risks.
Thank you, Jeff, for this quite good example of some good cases, especially regarding young and local university participation. Hopefully will be more research coming into this domain, which I would like to see more, especially around Grenfell area, in particular in North Kensington, with some tangible data. If we can share this with the committee, I think that's what Councillor Spalding on the stressing on in this committee we try to see is try to look at tangible quality data in particular. Who else would like to come in? Sorry, I'm trying to see who was. We have Councillor Idris, yeah, and Councillor Thaklis, and then Councillor Chouhan. 3 questions.
Yes, I have 2 points. Thank you, Chair. The first point is a correction to Jeff. The event was held by the then deputy mayor, not the mayor. So that's just one correction. The other, my question is, how do we prevent suicide if not all victims share or show signs? In the report, it said not all victims share or show signs. So how do you pinpoint it? How do you, I mean, you can't help someone who, one, doesn't come for help, or you see a problem. So if the victims don't share or show signs, how can we give them help? This is my main question. Thank you.
I'm happy to take that if you'd like, Chair.
Yes, David, if you would.
It was Jeffrey Lake again.
Oh,
sorry.
Jeffrey. Okay, all right.
Yes. So Councillor Idris, yes, it's absolutely the case that the risk factors for suicide are in many cases quite common, and therefore in relation to suicide prevention, we're often identifying opportunities where it might be possible to intervene. I think the point that Professor Appleby mentioned about cultural change is really significant here, and actually that's exactly what a suicide safe community initiative would seek to deliver, essentially by very much delivering a step change in the availability of training to voluntary and community sector partners around suicide, so that there is a willingness and an ability to talk about these issues, and an awareness of the importance of reaching out when we might have a concern. And I think it is very much seeking to build that psychological safety within a community, that is the way in which we can look to respond to what otherwise these are risk factors that are common in our communities.
Thank you.
Okay, thank you, Jeff. That's Councillor Sexter, please, your question.
Thank you, Chair. I don't really know who to answer this question, but I'd love Mr. Lake to answer. I was just wondering, it's just a quick question. Were the Public Health England guidelines in identifying and responding to suicide clutters followed? And if so, may we see the record?
Yes, sure. So you're right. Public Health England identify how suicide clusters should be identified, and it basically identifies the different sorts of ways in which suicide potentially can be connected. So whether that's geographically or in relation to particular social networks, to particular interests, whether it's people with particular service histories, be that mental health, substance misuse, or otherwise, social media usage and the like. So in terms of our approach to surveillance, we've got very, very good relationships with local partners, including the police, and we get that information. We then have a process embedded where we review each of those cases, so that we ask ourselves after each time we have the notification of a possible suicide, is there potentially a pattern here in relation to geography or age or method or any of those other possible ways that suicides can be connected, and very much with the Public Health England model in mind. And then we produce a serious incident report on anything that we identify through that, which then goes to the Adult Social Care Director for review and on to lead members. We have a well embedded process for reviewing that.
Thank you, Mr. Lake.
Thank you, Jeff. Councillor Chauhan, please.
Thank you, Chair. I just have a brief question on the update on actions taken on the recommendations, and primarily on section 7, which is on page 7, on the commitment to long-term focus. My question is on the kind of resources in the kind of actions taken already. We talk about schools responsible for the training of each of their staff members to locally improve access to mental health referrals, I guess. So how what is anticipated when there's an increased awareness of parents and children to access mental health services, when the bottleneck will be within the community mental health services? In other words, not enough specialist resources. How do you expect to bridge that gap? I don't know who could answer this, but there's
David will answer this.
Thank you.
Yeah, I think that in some ways that ties in with a bit of the national issue in terms of mental health being everyone's concern, and particularly that in the Kensington and Chelsea borough, there is a pilot that came from the Department of Health for mental health teams in schools, which is provided through the voluntary sector organisation Mind, who we work quite closely with, and as do our CAMS services also work quite closely with them. So they have a remit to go into schools to raise awareness of children's emotional health and well-being, to provide some support to children and young people and to their parents about their emotional health and well-being, and also to help schools develop a whole schools approach. And so that is highlighting to teachers and to school caretakers and to mealtime supervisors and to all community staff, all staff within the school environment. The importance of being able to talk about emotions and feelings, and being able to talk about how you can get access to help and have that happen very early on, so that we aren't waiting until people are into a crisis and when they need to present in a crisis, but actually doing a lot of preventative work. And I think that the idea, is very much about having a much more emotionally literate community as these children are growing up, who are much more able to identify their own needs, be able to understand how to get those problems solved. And some of the interventions are very much around creating solutions to emotional distress and upset, so that actually, as they are growing up and getting into adulthood, they've had a very good basis for creating solutions and creating ways of managing difficulties, so that they don't become overwhelmed by them later on in life.
So that's very helpful. I was thinking more of the acute stage. I mean, when there's a delay in referring on, there's many months, 3 or 4 months. How are we going to address that? I mean, it's really important to have that prevention strategy, and to have that kind of arm of reassurance around our children and young adults. But I feel that there is some technical specialist services that are difficult to access, and that's my concern. That I can't see how that would be addressed. Yes, we can certainly train. Mental health is certainly everybody's business, every one of us as a role. But when it comes to specialist intervention, I feel that there may be some work needed to be bridged there, especially with the NHS long-term plan, which is a 10-year plan, which is supporting nearly 380,000 more people to get therapy for depression. How are we going to fulfil that objective? I mean, are we aligned with the long-term plan?
I mean, I think that part of the work in terms of the schools teams, it does actually fit into some of the long-term plan for the NHS. It is through our working together with partners that we hope to be able to free up some of our more specialist provisions by having an earlier intervention. So the work that some of our excellent voluntary sector partners do, and by supporting them to support children and young people so that as I was saying, rather than them arriving in crisis, that they are diverted away into appropriate help and support at an earlier point, which I think also hopefully frees up some of our more expert professions to be able to deal with those that are arriving in crisis. However, no doubt, you know, we need to keep looking at that, because I think things like the pandemic have contributed to that nationally, and I think it is something that we should, you know, stay alert to and aware of.
And maybe, David, if I can come in at that point, there is an investment, something called the Mental Health Investment Standard, of showing a net growth over the years that match the mental health strategy. And it may well be, Chair, that in a meeting in the future we give you an update in terms of the borough generally around the mainstream services and how that investment standard, both for adults and children, is progressing, and actually what new services are being developed as a result of that. And that may well pick up some of what's just been raised.
That's very helpful, Robin. Thanks.
Yes.
Welcome an update. Yeah. Thank you, Marwan.
Thank you, Councillor Shahan. Yeah, it's can I just come in here just before I take further questions on the key point 7 on the commitment for the long term and the future for children and young people. I really do welcome that offer of volunteering and opening opportunities on apprenticeship program, but for the benefit of those who are listening to us, and we are for the benefit of this session, can we put like a link of how people can access and get more information to get involved, because I think this is a very vital area for the long term. So please, can we ask across as well the other area where there are some good cases being highlighted during our talk now, if we can draw attention to and be involved, so hopefully this can be incorporated in future tidying up of these reports for better data communication between us as a scrutiny committee and the public. I think there is a scope there for showing good cases as well as communicating some of the key issues you just highlighted to us, which is I can't see any link for people to access. So please, can we have that included later? Yeah.
Yeah.
And this is for public health as well as the Grenfell Wellbeing Center. Councillor Spalding, he wants to come back here. Do I have any more questions?
Just a brief one. Yeah, thank you. It's encouraging to hear all the things that are being done, you know, especially in schools and with university students. I was a principal of a FE college for 30 years, and it was engineering, so it was mostly young men, and I'm very acutely aware of this pandemic of suicide amongst young men. But I get no sense of urgency about what I've heard. You know, I praise what I have heard, but it's what's not being said that worries me. We've heard the reference to single-person households, but I think we really, as a conclusion of this, have got to do something about the major cause of death in young men under 50. I think we're being very complacent about this statistic, and I don't see any evidence that we are reaching out to these new hard, see some initiative aimed at these young men, because I really feel for them. And I think they're neglected. It's a real male health issue. It's 3 times the rate for females. If any other disease had that statistic, there would be all sorts of initiatives aimed at it. And I've seen nothing here tonight. So I really like that minute, and I think we ought to be doing that. And I'd like to see results, because whatever we are doing isn't working, because it's still the major cause of death in young males under 50. I mean, we could do something about people on benefits. We could do, I mean, university students are very privileged. What about the underprivileged who are not at university? We could do something about, I'm glad to see under paragraph 7 on page 7, we're referring to apprenticeships. But also, you know, there are all sorts of clubs and groups that young males attend. And I think we could do something more to reach out to these groups of young men who have got this terrible statistic of the major cause of death and 3 times that of females. I really can't emphasize that enough. Thank you, Chairman.
Thank you, Councillor Spalding. I think points being taken, and thanks for this emphasis. I can see heads nodding there. Thanks so much, Robin. And thank you all for this contribution. I have no further questions on this item. I am very grateful to all those who contributed without mentioning specific names. Thanks again for all the officers who helped and all the points taken to review and improve that reports. I'm sure there are always room for data quality there to be highlighted, especially Councillor Spalding highlighted a very key issue that needs to be addressed urgently in terms of quantifying those data and revisiting that area. Thank you so much for everyone contributing to this item on the agenda for suicide prevention. I come close to this item and I move on now to item A5 on primary care. I will, for this item, A5, we have 2 reports on primary care for discussion in this evening. One from West London CCG and Primary Care Networks, and the other on experience on using primary care services and help. If members agree, I will take them both as read. I understand that Dr. Andrew Steeden, with Borough Chair for West London CCG, and Janet Cree, the Chief Operating Officer for NWL CCG, and a number of the colleagues are here with us to answer our questions. As well as the Primary Care Network clinical directors, we have, I believe, Dr. Simon Ramsden, who's the clinical director for West Hill Health PCN, the Primary Care Network, Dr. Vikram Murphy, Kensington Chelsea South PCN, Dr. Yasmin Razak, Neo Health PCN, and Dr. Fiona Butler, Brompton Health PCN, and Olivia Clymer, the Executive Officer for HealthWatch, is also here to answer questions on the reports. I will ask Dr. questions first to Dr. Steeden and his colleague, members of the conference, by councillors attending and members of the public who wrote to us. So please, may I have colleagues wants to ask any questions on the report on primary care? Do we have any colleague, any councillor? I will just give you a little bit of thought. Councillor Williams, okay, I can see you.
Yes, thank you.
You have, okay.
Yes, I'd really like to sort of hear the response of the CCG to the report from HealthWatch, which is, I think, focused really on communication with patients and that some of the issues they have with access to primary care now, and with the message that now we're hopefully over the peak. Can we get back to normal with obviously learning the lessons which from having to do things, and some very positive, from having to do things differently in the last year, are all practices being encouraged to regularly keep their patients updated with how things are going in terms of how people access services, and whether there is now what can be done to make things easier for people who perhaps are not comfortable with digital technology.
So thanks very much.
Councillor Williams. Yeah.
Thanks, Councillor Williams. First of all, I probably should explain that West London CCG no longer exists. Actually, as of the 1st of April, we became part of North West London CCG, hence the change in my title and the title of some of the people I'm going to be introducing you to. So I, like everyone, I found Healthwatch's report incredibly interesting. It shared with me lots of insights that I think I was getting from some of my patients and some of my colleagues as well. We've gone through an incredibly difficult year, the last year, when we've not only had the enormity of a health emergency to deal with on the front line, we've also had to keep staff healthy and well, and patients as well. We've changed the way we worked almost overnight to a total triage and telephone advice system, a change which we all hope is temporary and that we can reverse back to normal, whatever normal is, in the very, very near future, and increase the number of face-to-face appointments that we have. But I think a lot of people have found some of the initiatives with some of the IT things like video calling patients has been really welcomed and has been quite successful. But I think we're all very keen to get back to as many face-to-face appointments as we can going forward. I know I was talking to one of my colleagues, Naomi, before this. I don't know if she wants to share some of her insights in this.
Oh, yes, good.
Hi.
Yeah, thank you, Dr. Stephen. Yes, please, go ahead.
Hi, my name is Naomi and I'm one of the clinical directors of West Hill Health. And we've done quite a series of surveys out to our patients about how they've felt about the changing appointment types. First of all, what I can tell you is that we are running now, in comparison to 2 years ago, April 2 years ago, we are running at about 110 to 115% more capacity and more appointments. Okay, so actually last year it was slightly different because we were at the start of lockdown. But when we're looking at this week, this month, 2 years ago, we are offering much more appointments in primary care than we were 2 years ago. So just to put that out there. Second of all, we have sent lots of surveys out to our patients. They're not like Healthwatch surveys. We send them to the whole population of our practices. They are run by SurveyMonkey and we get results relatively quickly. And more than 50% want to keep it the same way than it is now. In fact, I think it was about 73% when we last did the survey, and we repeat them 6 monthly. People like having the telephone access. They like being able to deal with what they can by telephone and have the option to see practices face to face. I just want to say that we have had a lot of business as usual care throughout the pandemic. All our patients have had their mental health review. We've done thousands and thousands of diabetic checks, thousands of asthma checks. Some of the asthma checks have been remotely, but all of the diabetic checks have involved people coming in and checking their feet and checking their bloods. And we are seeing that people's health in terms of diabetes has deteriorated, and we're working extremely hard to support those patients. So that's just in response to what we are doing in primary care. It is busier than it's ever been before. And in addition, we've had the incredible opportunity of doing COVID vaccination, which has put another level of complexity to our practices, but has meant that it's been run by our GPs in our practices. We are seeing our patients in the COVID vaccine centres. We've diagnosed lots of things in the COVID vaccine centres as well, and that care has been really good. And also the pop-ups, when patients do come in and get their vaccine, we are offering them all the care that they need, more than that they would have had 2 years ago in terms of appointments.
Sorry, just to clarify there, is it the when they turn up for vaccination, I mean, do they get other, in addition to that vaccination, do they get additional attention to other issues?
So in pop-up clinics, yes. In pop-up clinics last week, I did about 5 mental health reviews at the same time as I was doing vaccination. In our main vaccination centres, we're not, but they can always talk to a doctor, and I never go a clinic without, can you look at my rash? Can I just discuss this quickly with you, doctor? My PSA wasn't quite right. It's that access. I saw 3 people today that I had seen yesterday in clinic and said to me, I need to see you face to face tomorrow, and we do that. So that access is really important, and the patients know how to get hold of us now. They really do. And different practices are using slightly different models, but overall it is telephone first, and they are still seeing their patients, and we are still seeing a lot of people face to face. And that's
thank you very much.
The results of our surveys are saying.
Thank you. Yeah, sorry, I interrupted Dr. Stephen. Yeah, you were going to say something?
No, that's fine.
No, I do apologize. Yeah, okay. Okay, I have a few questions. Councillor Spalding, please. Yeah.
Thank you, Chairman. I'm looking at the report, and I'm not quite sure who the author is. It may be Dr. Steeden or his team, but I've got a couple of observations and one question. The first few pages are fantastic information for us. And then we picked up the point that Councillor Williams made on page 7, continue and strengthen video and phone consultations. I know there's been a lot of difficulty with people trying to do online consultations. I've heard of Dr. IQ causing problems to people who are maybe sight impaired or have physical problems, or just have never got to grips with digital technology. And so on page 8, it talks about the new network of responsive and proactive care and patients discharged from hospital. Well, that links me to the Health Watch reports. I think we've still got an issue with discharge from hospital and care transferring back to primary GP care. The hospitals are particularly good at this. All the reports I have of hospital discharge are particularly good, but I have examples where patients who are at risk, even their lives are at risk, are not picked up by the GPs for anything up to 3 months or more, and letters from discharge letters are not picked up by GPs. And I think we've got a weakness there. It's always been identified by this committee in the past, and I'm surprised it hasn't come up as an issue. The next question is on page 8 and 9 and so on. It talks about improving services for patients. Now, the general drift of this report is what I might call supply side, if you will forgive me. And it's very inward looking, and it's about administrative arrangements, management arrangements, reconfiguring groups, networks, all of practitioners, all on the supply side. Now, I struggle to find anything in the report about improving services for patients from a patient's point of view, except on page 9, when the last but one bullet point refers to allow the development of new enhanced services to be made available to patients referrals between practices. That's the only, and I don't know what that means, enhanced in inverted commas, but that's the only thing in here that actually refers to the patients getting something improved. Finally, on page 11, this is a focused question. The last bullet point, opportunity for recruitment for roles that have a focus on prevention. I just wonder what these new roles are. Are they medical roles, administrative roles, social workers, and so on? So those are my observations and my one specific question. Thank you, Chairman.
Thanks very much.
Thank you, Councillor Spalding. Okay, over to you, Dr. Stephen. Who do you want to direct it to?
Thanks, Dr. Spalding, Councillor Spalding, for that. On your point around supporting discharge, one of the big initiatives that West London CCG started 5 or 6 years ago to improve patients discharged from hospital is the My Care My Way project, which hopefully has improved patients' experience around how they are safely supported in their discharge process and picked up by the My Care My Way team, which is an integral part of the primary care team that's working in the community now. So hopefully your stories of patients being missed for 3 months is an ever decreasing number of patients experience that, and I certainly hope that's the case, and would be willing to investigate anywhere that wasn't the case. In a very specific point around prevention and the case managers and social prescribing link workers, these are roles that we currently have in some practices which are part of My Care My Way. My Care My Way is a team of therapists and case managers who support primary care in looking at a patient and their family and support network in a very holistic way. So we don't just view patients as a particular health problem, but look at their entire needs, which means often there's interventions that we can offer through social prescribing which aren't medical, whether that's a befriending service or a singing dementia service or help with the shopping or other things. These are services that we can support patients with. So this is about extending the work that we're already doing with My Care My Way and investing in that going future. I'm sorry that there isn't more detail on the work we're doing around engagement and patient services. I think we tried to keep the report as brief as possible and as succinct as possible, understanding that probably there'd be a lot of interest in the COVID, the changes due to COVID and the vaccination program. It's very true that we've had a very top-down control management system since we went into the health emergency by necessity. That means that we haven't had the opportunity and I fear the capacity to have as much engagement as we would do normally in West London. But as you've already said, hopefully we're coming out of this now and we'll be able to go back to old behaviours and increase our engagement with patients and families.
Yeah, thank you, Dr. Stephen. I think the patients will be, as Councillor Spalding pointing at, is the patients at the center of the provision of the primary care. And I think that's the point I read, and I'm sure you are responded to a very in a good way. I have Councillor Round and then Olivia Clymer after, please. 2 questions. Okay, Councillor Round.
Thank you. I just wanted to raise a few points about the vaccine rollout. So firstly, my understanding is that the council would benefit from being given a clear forward plan by GPs, because currently the lack of this means that the council's communications are limited, and with a more, with the heads up sooner, we'd be able to reach more people and faster. And I also know that the council has offered volunteers to GP surgeries to try and help ring the residents to get vaccinated, and yet we remain second bottom in the UK. So I just wanted to ask when the GPs will be reviewing their lists and looking at the data for deceased and non-resident patients. And then secondly, what additional resource will they be putting forward through the CCG to push us up the table to protect more residents? And finally, just more out of curiosity, could you inform me of the plans for us youngsters? I know that in the USA, appointments have been opened up for people under 40 once people above 40 were vaccinated. Do we know if we're going to be doing something similar here in England? Thank you.
So thanks very much, Councillor Round. I know practices are already working on cleaning their lists, and the need to call patients to book them in for appointments has made it very clear that sometimes their details on patients aren't accurate. So I know practices are already reducing their list size. I must say that a lot of practices are increasing their list size too, because people are registering with their GPs who may never have had an NHS GP before too. I've got to thank the local authority for their help and support with phoning around patients and getting them to book appointments. I think we've seen an increase in the number of people who've been making appointments for vaccines since that happened. Central and West have done that. I think there are some, and I'm sure, Councillor Rand, you're aware of some of the reasons why it's going to be difficult for Westminster and West London CCGs to move up the table because of the way that figures are being counted and percentages are being set. With regard to the onward planning of vaccinations, I could probably pass over to Fiona, who's one of our CDs who's been leading at the VM. Fiona?
Sorry, just before that, what about being given sort of a forward plan on the pop-up centres? Or
Yep.
Sorry if I missed that in your response.
No problem. I'll pass you over to Fiona because Fiona explains
Great.
how we're doing that.
Okay, and actually, I'm sure that Naomi and CDs from the north at St Charles's will want to come in. So I'm a CD in the south of the borough, but also responsible for Violet Melchett Centre. Excuse me if I've misunderstood the question, but I think you're asking about a forward plan for vaccinating from here on in. And how all the different centres work together maybe. So we're the local centres run by the primary care networks, and we've really focused all our efforts on doing cohorts 1 to 9, which are the over 50s, clinically vulnerable, and the health workers and carers. And those are the targets that we're most familiar with now. And we've worked very much in conjunction with local authority who've been supporting the pop-ups. I mean, I can talk about probably there's been more pop-up activity in the north, but we've definitely started in the south, and we've been running pop-ups, very much working together, which has been really rewarding with the local authorities and also with the mass vac centres to run some sites on World's End. And actually often, because this programme is quite reactive, there hasn't been a lot of forward planning, and it's whenever we can fit that in. So we're doing some first dosing still to use the evergreen approach of ensuring that we can mop up anyone who's in our groups above, the cohorts 1 to 9 to improve our targets. So we're doing some of that work, and also the pop-ups are helping us with that, and also really focusing on our second doses. The big group, which is everyone who's in the under 50s, so the sort of 20 to 50, the plan generally for our area in West London is for that to be picked up by the mass vaccination sites, and ours is at the Science Museum, which people will be aware of, and that will go out by mass invitation to try and get all our population coverage. So I don't know if that helps cover what your question was.
It does. So it means it is informative, but I just wonder, do you think that is going to lift us up from being only Hackney is currently has less people under 50 vaccinated than Kensington and Chelsea. So do you think that plan is going to help us go up?
Yeah, so I think that the figures are coming up. I think there are a lot of reasons underlying why it's been why the figures look as they do. One of the issues is that we're in an area where often people aren't in London and are not around. I'm sure other CDs will want to come in on their personal experience with that. So one of the things you could say is that, do these people exist? If you're ringing them, and we are as GPs ringing them on multiple occasions, we can't get through. Does that mean that actually they're what we call ghosts on our lists and they don't exist? Well, we have a huge number of people who are away, out of London or out of the country, thinking they don't exist. And if they do come back and we do want to catch them, then if they don't have GP care, that would be a worry and concern. But I think that's probably underlying. I'm not saying that it is the entire reason, but it does underlie we're in an area where a lot of people are out of London. I think the evergreen approach is really important for us, that we need to do everything we can to keep going with our targets and really work together across the system. So, it's a really good opportunity for health and social care to work together, in fact, across the whole community, to try and really uplift these figures. Pop-ups and community working is a really important way to do that. And it may be that my colleagues in the North could add some specifics of some of the great work that's been going on up there.
Well, thank you very much. And Mr. Chairman, my last point, promise, is firstly, thank you for what you're doing. But I guess, what I was going to say is if there are more volunteers being offered to help speed this up, obviously, I see Katz is going to come in on that. And
I just want to tell you a little bit about volunteers.
Sorry, I missed that. So the other thing I just wanted to say, what I don't understand is, maybe this is the rules, but if you can't get through to that person, can you then not just move your way down and then go into other age brackets for the eager 30-year-olds who are desperate to be able to do stuff as well?
No, so the rules are quite clear that we've got to stay within the cohorts because of the limited amount of vaccine available. It's monitored centrally when we go out of the cohorts that we're supposed to vaccine, because of course the theory is if you go down the age cohorts, people are less at risk, and therefore we're using vaccine on people who are less at risk while we've still got relatively limited amounts of vaccine available. So we are policed against that quite closely. But Naomi, you were going to say something?
Yeah, a few things that I just want to pick up with Councillor Round. First of all, I don't know if you've seen the WISIC data, but actually we are not the worst in London at all. The WISIC data shows us that even in North West London, both Central London and Hammersmith and Fulham are doing considerably worse than us. Okay, so that's point number one. And I'm happy if you want me to share my screen. If I can share my screen, I can show you that data right away. Is that possible?
That would be nice.
Only the meeting organisers can do it, but I can share my screen to the WISIC data right away. Can I do that?
I can briefly make you a presenter. Give me 1 second.
Thank you. The second point I want to make is, Councillor Round, with volunteers, we were really very, very grateful to have received support of a volunteer on the 13th of March. We set them up with smart cards, asked them to come in, and they've been in the practice for 3 hours because various things have happened, and we've now had 3 different volunteers offered. So we would love volunteers. If you can find us volunteers that can actually come and make those phone calls, that would be really, really, really gratefully received. But I'm not sure what actually happens on the ground. I've probably spent maybe 10 hours trying to negotiate with a volunteer backwards, forwards on emails. So that doesn't always happen quite like that. So just to put that into perspective, can I share my screen now?
Yep.
Right, okie dokie. So this is the WISIC data, and here you can see this is for the whole population. You've got Brent at 36.99%, Central London at 31%, Ealing at 39%, Hammersmith at 27%, and we're at 35%. I'm not saying we're doing brilliantly, but we're not doing as badly as all of that. And then we can actually look at the actual cohorts we're allowed to be doing, which at the moment is these cohorts. All right. So we would love to be able to be doing more cohorts, but at this moment we cannot. OK, so that is that. The other screen I just want to show you quickly is a Survey Monkey of all of our, oh, sorry, I'm gonna have to come back into that in 1 second.
Could you just show that screen again? That was so quick. I missed that. That was really interesting. That screen you just shared.
What, the previous one?
Yeah, sorry.
Or the Survey Monkey?
The previous one.
Okay, I'm going to try and do that for you now. Oh, my computer. Okay, here we go. Can you see it now?
And whilst we're waiting for Naomi, so I'm one of the other CDs in the north, and I think the other really exciting part about the data is actually it shows that as a borough we have not we have the same uptake in the deprived centiles as the least deprived centiles, and that doesn't stand for any other part of northwest London. That's very much due to the partnerships that we built with our community and working actually closely with the council as well with our pop-ups and getting the message out there. So I think that's something we should be proud of, but I'm sure that data, Naomi, if she clicks the button on there, she can work it out and share it. But it's a lovely graph to see. And other boroughs, unfortunately, the deprivation line is a lot clearer. So the more deprived the area, the less vaccine is going into that population. But that's definitely not something that we're seeing in RBKC.
So are we the West London one then?
Yes, we're West London.
So sorry, did you say Ealing was a lot worse?
No, I said that Hammersmith and Fulham.
Oh yeah.
And Central London. I was just challenging the point that you made that we were worse than the second worst in the country. It's not quite accurate, so I just wanted to have that point. And I also wanted to say, Councillor Rand, I don't think if you realise we're working 7 days a week. Okay.
So I'm not meaning to criticise. I'm just curious.
I think
we get to ask questions.
No. I just want to tell you the walk-ins that we've done. We've done thousands of walk-ins on Sundays. We've sent mass texts out to anyone that's eligible. So if they're at risk or extremely vulnerable, we have had thousands of people just walk through our doors with no appointments required because they're eligible. All they need to show us is a text saying they're eligible. We've called them, we've chased them, we've gone to their mosques.
I'm not blaming anyone. I'm just trying to identify what it is that is not helping. And I'm not saying it's your fault. I'm just this meeting. So I'm sorry if that's how you interpreted this. No. It's not the point. For us as councillors, it's really helpful to hear what you think the stumbling blocks are, that we are, as the stats say, just lower than other areas. And it's not, you are fantastic, everything you've done.
No, so but can I just say, we have done a survey of why we aren't getting the decliners as well. And I can show you the results of that if you'd like to see that, where we're specifically asking our patients why they're not having it. Some of it, 51%, are because they're not in London. Okay. So I'm happy to show you that data as well. I'm not taking this critical. I'm literally trying to give you the responses to your questions. And so 51% aren't in London, which is a common problem. And I do think it's worse in our borough than in other boroughs. It'd be interesting to get those stats from somewhere else. And second of all, it's not because of this. Do you want me to show you the results of that survey? Would you like to see it or?
No, email's fine. I don't hold everything up or maybe.
Can we share it with the committee, please, later with all the email us? We'll highlight these ones. Thanks so much, Naomi. Yes. Can I have a question from Olivia Clymer, please? And then she's been waiting patiently long enough. Sorry, I had to interject some of the comments because it follows with some data and statistics. So, Olivia, please, your question.
Yeah, thank you, Councillor. Just wanted to follow protocol. I'd just like to come back on a few of the points because we've not really had answers to the points put in the Health Watch paper. There were a good number And it's really not just about COVID, it is about people's experiences currently of primary care. At the start of the paper, we acknowledge the considerable contribution and dedication that has been shown by the NHS during this paper, and a number of our very hard working local MPs, and we have to give a big up to Neo Health, who have just been on. I'd just like to take up the point made by Naomi Katz. I would challenge and would like to see evidence around an increased capacity of patient access. Our paper draws attention to the nature of what is defined by patient access and by an appointment. So I'd be really interested to see the data on that, because what does that mean? Is it a repeat prescription? Is it an interaction on Dr. IQ, which we know people have challenges with? As Healthwatch, we are part of your independent regulatory framework, and we need to draw these things to your attention. So there's an opportunity, as I know you're very keen to do, to improve communication. For example, just the basics of your website and the messages left on your answer phone messages, which could make a considerable contribution. So I just wanted to pop onto that, and thank you, Naomi. We'd love to use your text messaging mechanisms to encourage people to complete independent surveys on that. That would be an excellent opportunity. Unfortunately, to date, we haven't been able to, because I understand there's a charge with that. Although in our report we do draw to people's attention the fact that in some practices there is quite an insistent use of those messages to get people to use the IT and that route, which might not always be suitable or appropriate. So I just wanted to make those comments before we have further questions from councillors on the papers. Thank you.
Thank you very much, Olivia. I think it's always patients should be, and I'm sure all of you agree that they are the center of our operation, because the whole operation exists because of patients, isn't it? So, and these make it easy for patients to respond and addressing these issues in a timely manner. I would like to take a question, if you don't mind, from Councillor Wait. She's been waiting patiently as well. I do apologize for long wait. And Councillor Healy, and then Christine Vegas after.
Councillor Thaxter.
And Councillor Thaxter, please.
Yes, it's about touches on when a GP practice is taken over as a vaccination centre, and the ability of the GP practice to be able to deliver its services at the same time, concurrently. I'm talking specifically about the Earls Court Health and Wellbeing Centre, which has been a centre hub for vaccination in the borough. I think that it has presented problems for patients being able to actually access services. There have also been issues when the supplies haven't arrived, and a post-it note on the front door really doesn't cut it. So I think communication is important. And I agree with the comments made about Dr. IQ. It does present issues. It doesn't do everything that it says on the can, and there are growing concerns. So if somebody could possibly, and are there guarantees of supplies? And is that the reason why things are suddenly dropped when people, the reason why I mention it is on Saturday, there was a line of people going right round the block into Earls Court Road, where there were 2 batches of Saturday appointments. There must have been at least 25 people for a 9 o'clock appointment. No social distancing, and this was supposed to be the vulnerable and over 70s. So I think communication management is very important.
So if I can come back to you on the vaccine supply, the NHSE is running what's called a push program for delivering vaccine, which means that our CDs and our PCNs have really not known what vaccine is going to be delivered until very close to the actual time of the clinics, which has caused a lot of headaches and problems for them, completely not of their own doing. It's partly to do with the fact that nationally we get vaccine very close to the time it's used from abroad, which means that the government then has, or the NHSE then has to send out vaccine as it becomes available. So I'm really sorry that you had that experience on Saturday. I know most of the time things have gone incredibly well, and in North West London we were the first ICS in the country to vaccinate over 1 million, give over 1 million vaccines, and we in North West London have given over a quarter of all the vaccines that have been delivered in London itself. So I think both the PCNs, the hospitals, and the mass vaccine sites. And
I'm not querying that,
no.
But there's a difference between hitting targets and actually management. Management and communication. All right. So you don't have the vaccine. You communicate you don't have the vaccine, so people don't turn up. If you're rescheduling appointments, you don't double book. So you have so many people coming into a constrained space, which makes it logistically difficult. So I'm not querying that you're doing everything you can, but it's about management and communication.
Yeah, no, I understand. And if there was a problem on Saturday, I apologise for that. I don't know the details of what happened at Earls Court Medical Centre. I know that all the PCNs in West London had to reschedule over 20,000 vaccines appointments over the last few weeks and are continuing to have to do that. So,
but you haven't also answered the question about what happens to the service to patients during that time.
So vaccination was a priority when we moved into the new year, and what has happened, the practices have had the choice over the last few weeks to say if they wanted to carry on vaccinating the new cohorts to go down, but they had to make a guarantee that they had the capacity and ability to carry on business as usual as we come out of the COVID surge. So I think all the practices in West London all the PCNs have decided that they will carry on doing second doses and trying to mop up those people that haven't had a vaccine in cohorts 1 to 9, but they won't. They are going to be prioritising going back to business as usual going forward.
Thank you.
Thank you. Thank you for this clarification. What I said, Councillor Healy, please. Yeah.
Thank you, Chair. I want to change the subject entirely. We are dealing with primary care, and as you and the rest of the committee are aware, there is a new threat to the provision of primary care in this borough and indeed in other parts of the North West London collaboration of CCGs. I'm referring to the purchase by Operose, a subsidiary of Centene, of GP practices in this borough. They've taken over 3 of our practices, Earls Court, Kings Road and Barby, which is based on St Charles Hospital in my ward. And this has been done without any consultation or information to patients, without, as far as I can see, any due diligence. And the contracts seem to have been agreed just as the borough-based CCGs went out of practice into the new one CCG covering the whole of North West London. Now, I know this is a controversial thing, and there will be protests outside some of the affected practices on this coming Thursday. But as a select committee, surely you should be exercising proper scrutiny of this, because it does threaten the continuation of proper primary care to our local populations. It's not.
Thank you.
It's not possible to deal with this meeting at this late stage. What I want to suggest is that you call a separate meeting, possibly after May the 6th for obvious reasons, but to really examine this, because it's a really frightening thing and it is causing a great deal of anxiety locally.
Thank you, Councillor Healy. Yeah, I've read about that,
agree.
and I will, I will answer this in a minute after I take another question from Christine Pegars, please, and then Councillor Thexter.
Thank you. Yeah. I wanted to have more information really about how patients are going to be engaged and communicated with around the development of PCNs going forwards. We know that one of the responsibilities of PCNs is going to be population health and addressing inequalities. At the moment, patients are very much in the dark, really, about the configuration of PCNs, I mean, where they belong or what services are going to be offered, how things are going to be managed differently in terms of what you call enhanced services. So that's the communication side of it. But going forward, thinking about this major new responsibility, it's something that patients would want to be centrally involved in. And, you know, I'd like to know what plans you have and how we can work with you on it.
Yeah, lovely. That's a really good question.
Can I take one more question, please? Then take one more question, then we'll answer if you don't mind. Yes, Councillor Thexter.
Thank you, Chair. This is just a quick question. Based on observation and community networking, I would like to ask, how are at-risk patients monitored in order to deliver effective preventions of conditions such as CHD, diabetes, hypertension, and the list goes on?
Thank you. Okay, over to you, please.
So if I deal with that, yeah. So if I deal with that last point first, and then maybe get somebody else to help with the PCN engagement question. One of the things that hasn't stopped during COVID is the management of patient with long-term conditions. So we have had to identify those at-risk patients at the very beginning before the vaccination campaign started to make sure that they had care plans, they had support with medication and other services too if they were shielding. That has carried on as we've gone through the two waves of vaccine. 2 waves of the virus, and practices are still able to monitor those patients. Some of them do some of their monitoring remotely. Some of them do most of their monitoring face to face. So management of patients who are sick hasn't stopped as a result of COVID. Hopefully, in most cases. But with regard to PCN and engagement, Simon or Fiona, do you want to share anything here?
Certainly the patient participation groups have been carrying on to attempt to give information, to receive information, and have this dialogue we've all been talking about, putting this patient in the centre. It has to say that partly because of the command and control level 4 initiative that we're in, that's probably been restricted a little bit, and we're all deeply aware that all of the changes that we've initiated will need refining, will need improving, and we would absolutely want to work with patients to make sure that we get it done in the right way. There have been benefits of the new systems in terms of how we provide services, but there have also been areas that we can improve on, and I think no one for a moment would want not to say that. So we do look forward to improving and increasing our engagement with patients, but it has been going on all the time in the background, but perhaps to a lesser degree simply because of the emergency we were contending with.
Yeah, I mean, I might just add to that. I mean, I'd agree, just a perspective from the South. I think that PCNs are still nascent organisations. And I think that that is because we've been in a year of pandemic, and at the time when we were really trying to take off with population health and thinking about how to really engage community and work in the appropriate size to ensure that really sensitive response to population needs, that actually COVID hit us all. And that actually has in a lot of ways slowed us down. I personally feel really positive that it has, on a kind of wider scale, brought us closer together in that PC practices have worked really closely as PCNs over the COVID response. So not only the vaccinating that's been done at PCN level, but also we came together to offer the acute COVID hub response, so the alternative for hospital admission in the community. We came together to work to offer a home visiting service. So I do think we're in a really good position now to think about what population health means. I think we're closer to that. And I really welcome the thought about how we take off with that as we come out, hopefully, of the pandemic and really get closer to working together, whether it's small steps of even getting PPGs to work, to function and to work together across PCN so they've got a really stronger voice. Or even plans that are more ambitious. And I think, maybe, I don't know if Yasmin's still on the call, because NEO's done quite a lot of really exciting work around that kind of community engagement. And again, probably they've been a little bit slowed by COVID, but I don't know, I can't see whether Yasmin wants to come in on that.
Yeah, more than happy. I think the community is the answer, and I think we can't run without our community, and by taking ideas from our community, and then we can really deliver services together. I think that is the idea of PCN. So obviously the NHS England mandate is that we, of course, we have to run particular services as any service does in the public sector, and we have to almost prove we're running them by ticking boxes. But the idea of the PCN is, above that and beyond that. But we are, we're forming, we're in that stage. And this year has been a really good example of how well GPs can do when they come together, and not just one PCNs, but our 5 PCNs all working together collaboratively. And, as Fiona says, the successes aren't just the impact of the vaccine drive, which has been tremendous and involved all of our community, actually, in terms of volunteers coming to vaccinate at our centres. I'm just organising some more training tomorrow for our local community champions, but also the hot hub and absolutely everything that's happened this year, which has been tremendous as an effort. Completely, I think the hard thing has been the face-to-face has stopped. So how do we have face-to-face PPGs? We've all tried the online and we know it's not suitable. And we're all here today, and that's probably where maybe a cohort who can connect to Zoom and Teams, and it's easy for some, but it's not easy for everyone. And I think it is now about how we go back to doing that in a safe way. We are running group consultations for our patients to allow them a safe space online to communicate with us. We're working with our community champions to do that as well. In fact, any opportunity there is to engage, that's what we're here for. So I would say if anyone's also got ideas or groups who they're concerned about that haven't had access to their GP, just come forward and speak to your PCNCD, because that very much is our role.
Yeah, thank you. Thank you, Yasmin. That's very interesting. Can I ask Councillor Thexter, please, to come in? I can see her hand.
Sorry about this.
Follow up?
Thank you. Yeah, I was talking to Dr. Andrew. My question, he didn't really answer it because he was talking about management of existing service. I'm talking about prevention. Although he highlighted those issues, but I was talking about prevention. Those residents who are showing borderline or at risk of all these diseases, how are they being monitored?
Okay, yeah, that's, oh, sorry, then I misunderstood the question. I'm sorry.
Thank you.
That's okay. So certainly it's a priority as we get more time to do it going forward, that we will be working with prevention more and more. And in fact, we've already started conversations with RBKC and Westminster councils about how we can start to shape the agenda for the forming ICP, the Integrated Care Partnership, around preventing illness in the community, whether that's improving air quality or addressing obesity for diabetes and heart disease, other things as well. So there is a big focus on trying to help to prevent disease, and we're also talking to consultants in the hospitals too, who up till now have just been running outpatients for diseases, people with diseases, how they can help us to manage populations and keep populations well as treat people who get sick. Is that a more full answer for you?
Yeah, but what I'm trying to get at is, for example, one of your clients would come into the GP practice and basically they'll be tested for like borderline sugar levels. Yeah. Now, how often would you liaise with that client in order to make sure that they are keeping check of their health? Do you monitor them? Do you call them in on a regular basis? How do you do so on all these diet-related issues in order to prevent the exposure of these sort of diseases full blown?
Yeah, so there's with diabetes as an example, there's lots of really great work going on at the moment about how we pick up people before they've got diabetes and then monitor their blood sugars to try and stop them from getting diabetes. There's a national campaign around diabetes prevention that we can enroll patients in, and we're encouraged to enroll them in so that they get education about diet and exercise as well. That's a very popular program with the patients I've referred in. So there are specific prevention programs that we can refer into. Of course, every individual patient is slightly different. So although there's guidelines that you would probably do that blood test twice a year, it might well be that depending on age or other factors that you might want to tinker with any particular care plan for an individual patient. Is that helpful?
Yes, but I'll come back to you. Yes, but thank you so much for your answer. It's a bit clearer now. Thank you.
Follow up. Yeah, no problem. Thanks. Yeah, we had a few clarification there. Can I completely follow up then, Councillor Kisson? And so, Olivia, do you have a follow-up question?
Yeah, thank you very much, Councillor. Just want to get us back onto the primary care report. Can I go to,
yes, Olivia?
Yeah, thank you, Councillor. Just to bring us back to the primary care report, I'm very interested to hear that there have been PPGs operating. That's not what we found at Healthwatch. That's not what we're hearing. That's not what our surveys and our work have suggested. We've had investment from West London CCG for the last 4 years where we've provided support to GP practices who are still contractually obliged to provide a patient participation group, which is a two-way discussion and interaction at a practice level. So there's lots of useful information and experience to draw upon. Our experience have been that virtual PPGs can, I don't know if Dr. Steedon's having to go, that virtual GP practices, PPGs can work. And what we're hearing is that patients are struggling to understand what PCN they are in, who do they go to, what are the communication routes there. From the report, you'll note a very basic question around who do they contact and an email address for a practice manager that's not on GP practice website. So people might want to contact you. And the trouble when they do send a concern or complaint in, that the system doesn't allow them to take a copy of that or retain it, so they can't follow up and they don't know who and where that goes for. So those are just useful pieces of information and evidence that have been collected for hopefully what will get us a structured response. I'm really pleased to hear that you're going to move to business as usual in West London after your tremendous effort. And as my chair says, we'll look forward to working from you on these challenges of engagement at both that GP practice level, because if you can't do it at GP practice level, it's going to be a struggle to work at PCN level and upwards to ICPs.
Thanks very much. And your report was very useful, as I said before, and I think Simon and Joe are going to invite you to come to the PCC so that we can discuss the points that you raise in detail and see how we can implement them. I'm Yes, I mean, that's as much as I probably want to say. I mean, the GP contract was suspended during most of the emergency, so a lot of the things that were contractually we're obliged to do because of the nature of the emergency, we just weren't able to do. The contract is coming back now, so those things that we've done so well in the past, hopefully we will be able to reinitiate as well.
Yeah. So
thank you, Dr. Seelan. Yes, one simple
NHS
comment,
England
please. Yeah.
Have asked you to start work on PPGs again, so that's an opportunity to get that moving.
Can I just say some practices have had virtual PPGs? I know my
just quick one, please. Yeah.
My personal practice had one on the 28th of September. We obviously didn't have it the second time, but I do want to just reassure that we have had lots of Zoom meetings in terms of education for COVID vaccine, which is what we were meant to do in the interim period. So we have been engaging with our patients on Zoom, not necessarily with PPGs since January, but with COVID vaccination education sessions. But I think you make a really good point about on our practice website, you don't know how to make a pain complaint or how to, and we will change our websites to reflect that. So thank you.
Thank you. Thank you.
Thank you so much. Really it's quite useful. Excellent. Yeah, this is a kind of work we need. Proper criticism with some improvement. Thank you so much for taking that lightly and acting upon it. Councillor Atkinson, please.
The volunteers that are in PPGs are there to support you, who could help perhaps with some of the.
Thank you.
Thank you, Chair.
Thank you, Olivia. Thanks so much. Yeah, Councillor Atkinson, please. Yeah.
Thank you. I'm sorry to sort of go back a bit, but I would like. I was concerned by the report from Councillor Wade about her experience or observation in Earl's Court, and I just sort of perhaps wanted to balance this a little bit to say I've been volunteering at the vaccination centres at St Charles and at Violet Melchett, and I don't normally see it as my job to sit here and praise officers, but my experience is that both the centres have been extremely efficiently run, and that the idea of long queues is it just hasn't been my experience. They've relied heavily on volunteers and they've organised them properly. So nothing but bouquets on that. But I am concerned about what has happened in Earl's Court, and it would. I suppose what I want to urge is that those two centres away from GP surgeries continue for as long as possible, so that ordinary GP practices can go back to providing the general normal medical provision. And as you know, Chair, it's one of my concerns that I do want us to do some more work to find out just what the price has been, what we are falling behind on, and I would hope that you can organise a report back for that in time for the next session. And it would seem to me, from what Councillor Wade has said, it seems to me that individual GP surgeries should not be in the long term be seeking to deal with their own vaccination, because I really fear that the other things that you would normally do will suffer. I think the idea of younger people being encouraged to go to the Science Museum and the use of texting for young people is a good thing, and I'm hoping that nationally, that national government is going to give people, younger people, more incentive to come forward themselves. And whilst I wouldn't advocate over-dependence on texting for the older population, my experience is that hasn't happened. I do accept that some of the communications could have been done better, but far be it from me to encourage the NHS officers to blow their own trumpets or to make excuses in any way. But it has been an absolutely massive project, and I'm full of admiration for what has happened. And also, I would encourage officers to perhaps be a little more candid about the problems that have happened higher up the chain of command, that people only find out what vaccines they've got or they're not going to get very late in the day, and it's been necessary to scramble and change appointments. My own wife had her appointment changed at the last minute, but again, we were very impressed that a great deal of effort was put into contacting her and changing her appointment, and that I know was happening to thousands of people at the same time. So as I say, in that respect, officers should be standing up for yourselves more. But if I can finish on the point that it is horses for courses, and I don't want the NHS to do what the banks and the insurance companies have done, which is to allow yourselves to be led by technology, and whether people want to do it or not is certainly with the case of the banks, that we were told we couldn't have face-to-face service, we could rely on the telephone. As soon as we started relying on the telephone, we're then told to do it online. And I think that is a worry with older people. But I would say that there are some things that I am very happy to do online, and things which I was reluctant to do till I was made to do them. The whole idea of repeat prescriptions and treatment of physical illnesses by camera, face-to-face, works very well. But I hope that means that the traditional means of face-to-face consultations can still be preserved for mental illness. I mean, in some respects, showing your rash or whatever on the screen is quite easy to do, and having done it myself and then urged to use the new technology by my own children, it worked. But I'm still concerned about mental illness and people's of psychological conditions. I think you can't beat face to face on that.
Thank you, Councillor Atkinson. It's quite reassuring that I share the same experience happened to me in St. Charles. It's a perfect, beautiful operation with so many queues, well managed from operation perspective. So I really had that experience, and I'm sorry to hear about that shortfall in Earls Court, but I'm sure with your experience somewhere else, this can be accommodated because you have proven the operation on the ground in somewhere. So the shortfall happening in Earls Court in Councillor Wade highlight this will be addressed, and I'm sure, as you said, you are looking into it. Thank you, Dr. Stephen. What I would like to conclude here, James, I think left.
Thank you.
We kept him waiting for a long time. I'm here, James.
Councillor, hello. My name's James Benson. I'm the lead director for the Integrated Care Partnership in Kensington and Chelsea and QPP, and I'm also the Chief Operating Officer of CLCH. A few points I just wanted to address. Olivia, I will discuss with you in our catch-up how we engage with the public. I recognise the points that Andrew has made around the cessation of some of the clauses of the GP contract. I do know our PCN clinical directors have worked exceptionally hard. And I go to Dr. Butler's comment, which I thought was quite well made. We have delivered more integration and greater levels of service during a pandemic in the NHS than we have delivered in the last number of years. The art moving forward, when we are out of a pandemic, will be how we engage with the public, how we improve our services, and how we understand the level of capacity that we have. I would remind all colleagues, though, that we remain in a pandemic, and my colleagues in primary care and the rest of the NHS are attempting to deal with some of these challenges. I also recognise that the committee does need oversight, and I'll address some of those points directly with CCG colleagues outside of here.
Thank you so much, James, for this reassuring on those critical comments we made earlier. Do I have any more question? Because I have, oh, Naomi, she wants. Please make it very brief, as we have with Naomi. Maybe? No? Do you want to make any observation, comment? No.
No, thank you.
Okay, thank you very much. The item on raised by Councillor Wade earlier regarding the joining of the takeover of the different practices. I will deal with it. I will ask the CCG, please, if they can provide this committee within reasonable time, like within a week of report, just clarifying the situation, what's going on. So I will share it with the committee, and then we'll act upon that results. So I will appreciate that clarification. Robert Atkinson, Councillor Atkinson, want to come in? Yes. Just make it very brief, because I want to conclude this item, please.
Very pleased. I mean, exactly what you've said. Councillor Healy asked if necessary, could there be a special meeting on this? I mean, it's fine to get a report, but I think councillors do need to be able to react to it. And depending on what the report is, exactly. I think an urgent meeting is necessary. And I am extremely concerned that it seems to me, and I can understand why, that there is a medical crisis. We are struck by reorganisation, but it does seem to me, and I'm hoping it's not the case, but I fear it is, that there has been some sneaky privatisation slipped in here, and I think elected councillors need to have the possibility of querying this and to raise our concerns. So in this report, which I'm very glad to hear that you are commissioning, I want to know the timescale of when this was organised and who knew what when. Because
absolutely,
those of us who take an interest in health matters, it's taken us completely by surprise. So it's hardly surprising that many of us smell something very wrong here. So I hope we get a detailed report, and I hope that we are then given the opportunity to urgently respond to that report.
Thank you. Point taken, Councillor Atkinson. Yes, final point, Councillor Wade.
What is of enormous concern is this must have been going on for some time, and for this to become, everybody to become aware of it, and then the committee not to come to committee, for it not to be discussed, for open consultation. This is inappropriate. People feel vulnerable. They want to know. They realise that the NHS is even more important, and it's demonstrated that this year. And they just feel that we've let them down because we haven't been able to scrutinise it. This is a company that has taken over, that is actually under investigation in its home state in Missouri. Is it what safeguarding was done? What measures were taken to interrogate this company, and whether it was appropriate to take over? You know, the 80 medics only took over these three these GP practices last year, and yet they've already been taken over.
Thank you, Councillor Wade. We'll have, I think we have an agreement that we are going to get a detailed report on this to this committee as soon within a week, hopefully, if it is or it's appropriate there, and then. Will circulate to the committee members to take the appropriate action, and we might call for a special meeting. Excellent. Janet, do you want to come in? Ms. Cree?
Hi, I was just in response. Hi. Thank you, Chair. I'm Janet Cree. I'm the Chief Operating Officer for for this borough. It was just in response to that particular point. Obviously, there wasn't a particular issue that was raised prior to the meeting, but we absolutely are going to be able to provide all of the information and the due diligence that was done with at both locally but at a London level around this, so we can provide the report and just to reassure people that there is nothing, that all of the proper procedures and processes within the regulations have been followed. But the main point is that there is no change to the GP contract and the services that patients will receive. So that was the point I just wanted to make now, so people were reassured by that, but we will obviously provide the report as requested.
Well, I'm not.
Thank you very much, and then we'll act on it in due course. Thank you. I think Councillor Spalding, the last word there, and no comment, please, just question, because I need to move on.
Thank you, Chairman.
And Olivia, Councillor Spalding.
I think it's important for people who are observing this meeting and for the minutes to make it quite clear that this committee and the council itself has no role in managing GP practices or appointing them or contracting with them. This is purely the role of the North West London Clinical Commissioning Group, who agree contracts with GP practices, which by their nature are private partnerships, they're private businesses, and this contracting is something that we can scrutinise. We can invite the CCG to come here and answer questions, and we can invite GP practices and so on, but it's not our responsibility, but it is our job to scrutinise it on behalf of residents and patients. And I think we must make that very clear, Chairman. Thank you.
Thank you. Thank you so much. I appreciate that comments. Olivia?
Thank you, Chair. Just to say,
final word to you now, and then we close this item.
Thank you.
Olivia, please.
Healthwatch will be happy to support an item on that situation. It's active across London, Healthwatches, and we at your local Healthwatch have met with CQC, the lead for primary care, and the relationship manager on wider concerns. So we are working hard for the boroughs on this matter. Thank you.
Thank you, Olivia. Thank you so much. I'm really grateful to all the officers, to everyone from the West London CCG who contributed to this lively, accepting all the comments and the questions from our members. I'm really grateful, and I really thank you again on behalf of the committee for your patience and your honest opinions, sharing with us some critical issues on this. So I conclude this item, and thank you again, and good night. If you want to stay with us on the next item, you are welcome. But thank you so much again. Now I introduce the item A6. We are running slightly over time, but because of this importance of these issues, we allowed extra questions and discussions. And the item A6, the Select Committee Work Program report, and this is on the agenda, where this work program will be this municipal year. It's been very difficult. We all recognize it from practitioners, businesses, everyone. It was a very tough year for all of us. So we have been very patient to get things done. I'm really grateful to our health partners and council officers for all their hard work in this work during the health crisis, and I wish to extend all our appreciation, and which has really impacted us all. Yet we have reviewed most of the topics we've been prioritized for this year. So basically, 5 of the main topics we addressed, where we followed closely the phases of juncture of COVID-19 impact, and we recently had the last vivid discussion on the testing and vaccination, which is very interesting. And the recovery, health and social care reviewing in our October meeting and December, as well as in February meeting. We reviewed the adult social safeguarding in December 2020. We held a special meeting on the 19th of November to discuss the merger of the Royal Brompton and Harfield NHS Trust with Guy's and St. Thomas NHS Trust and its impact on patients and residents' healthcare. We've just reviewed the primary care provision and the other issues emerging from this merger and the different CCGs and the integrated healthcare. And we just reviewed a very sensitive, emotional topic on mental health in North Kensington, where we just heard the main author of the report, who kindly visited us tonight to give an insight into his work, Professor Appleby. And we are grateful to his work with us on this, and the report from the NCWL on the implementation and the adoption of these recommendations. And I will leave for the final working group for Councillor Williams to just give a brief update on his work with his group. And before I introduce him, I have proposed 2 important new issues going forward that I wish to bring to your attention as a committee member. So I suggest to this committee that we should consider inviting our NHS colleagues in Northwest London and West London CCGs to the committee meeting scheduled for June to discuss 2 main streams: the CCG recovery plans, which to inform the committee on their recovery and elected care plans, and the changes to health with the West London CCG dissolving into a local committee and the Northwest London becoming one single CCG. So this will be reinforced and circulated to the committee as a suggestion for future and forward work. And I will leave the last word to our Councillor Williams, if you want to say something about your work, Councillor.
Thank you, Chairman. As the note says, we haven't unfortunately made much progress. I think our next stage is to engage with community groups in North Kensington, but there's been quite a lot of other consultation on health-related topics with them, and I think I was a bit concerned about that. So we'll review the result of those consultations and information gathering exercises by CNWL for one, Public Health and others. And then I think my plan is to meet with the group. I know the other 2 members are here tonight. And then we will hopefully go into consultation with, that's my suggestion anyway, with community groups as the next stage.
Thank you, Councillor Williams. Yeah, that's really interesting, and thanks all for the contribution. Item F7, I did not receive any written questions except to thank everyone contributed to this discussion. I don't have the only urgent matter which we highlighted regarding requesting that information from the CCG at the moment. I left nothing here but to thank all those who involved with us tonight in this meeting on mental health, our guest speaker, and everybody, officers who are working very hard to conclude this meeting. And I wish you a very good night. The next meeting is scheduled for the 28th of June, 2021. So I have nothing further to say except to say to all of you, thank you again to all the support I got from our officers, Paula and Yasmin, and thank you, and have a safe and good night.
Thank you, Chairman. Good night.
Thank you, Chair. Thank
Good
you.
night.
All.
Thank you, Chair. Good night.
Thank you all.
Thank you, Chair. Good night.
Thank you. Very good night to you.
Thank you very much. Bye-bye.
Thank you. Okay, goodbye.